The broadcast is now starting. All attendees are in listen-only mode.
Good evening. Welcome to the PWSA USA webinar series. Tonight's topic is Prader-Willi Syndrome, Adulthood 101, presented by Elizabeth Roof. Before we dive into tonight's presentation, let's review some housekeeping notes. Please take a moment to write down the dial-in number and access code for tonight's presentation should you become disconnected. The number is 631-992-3221, and the access code is 238-678-293. For those of you using the voice IP option, you may choose the option of dialing in at any time during the presentation. There is a question segment planned towards the end. Please note that the dialog box located to the right of your screen has an option for you to ask questions throughout the presentation so nothing is forgotten. Your line is muted to alleviate distractions, so if you have any difficulties during the presentation or need assistance, please use this question box and I will be happy to provide assistance as best I can. Do not use the chat box, use the question box. If this dialog box is distracting to you, you can click the orange arrow at the top to minimize it, and then click the same arrow to open it again and enter questions or comments. Ms. Roof is well known to many of our families. She is a senior research specialist at the Vanderbilt Kennedy Center and has been a licensed health service provider in Tennessee since 1994. She currently directs several research programs with children and adults with Prader-Willi syndrome with Dr. Elizabeth Dykens. They have published many peer-reviewed journal articles and book chapters about PWS across the lifespan. Since 1995, Elizabeth has followed more than 300 children, teens, and adults with PWS in longitudinal research studies. She personally sees each child and family with her highly trained team and provides feedback to families and professionals on behavioral and classroom intervention, effective parenting, IEPs and educational strategies, medication recommendations, and residential placement. Through PWSA USA, she has produced a teacher training video on YouTube to help manage students with PWS. Elizabeth has presented at many national, state, and regional conferences to help professionals manage PWS in schools, homes, and vocational settings. She currently sees more than 50 patients with PWS in clinical medication trials since 2014 and is very interested in medications that treat Prader-Willi syndrome. I will now turn the presentation over to Elizabeth.
Hi, everybody. I really appreciate you taking the time in your evening and afternoon to listen to me talk about Adulthood 101. So I'm going to talk a little bit about the kind of trajectory, a little bit about what we study, and more about how what we study can help you as far as parents and professionals dealing with adults, and even kind of teens maybe heading into the adult years, kind of what to look for. So I work at the Vanderbilt Kennedy Center. We see people with developmental disabilities, and we do follow quite a few people with Prader-Willi syndrome. So my big interest is teens and adults with Prader-Willi syndrome, because I think a lot of times people are very interested in children, but as they get older, they're like, well, you know, that's not all that much, you know, interesting, and there's not a lot of interventions. But I'm really interested in ways we can actually help people who are adults with Prader-Willi have better quality of life and have families have better quality of life. So a lot of people talk about the old, you know, standard of, oh, people with Prader-Willi syndrome don't live very long, they don't live past 25 and things like that. And I know when I started in 95, that's what a lot of people told me. What I will tell you is that people with Prader-Willi are living longer than ever, and they have better health and a better outlook than ever before. And I think parents need to really think about a lifelong plan of support throughout their life and not just think, oh, I got them through school, I got them through this. It's a lifelong support plan, and so it's really important to have some transitional ideas in mind and to be planning for those things and not just think they're going to magically happen, because what I will tell you is that doesn't happen. If you don't plan, it's just like sending your kid to college. It won't happen. So you have to really think about what it is that would be best for your child. So to date, we actually started with Elizabeth Dykens in September 2003. We've gone through 2 different grants. The first one was looking specifically at compulsive behavior and how it changes over time, like lifespan. And the second one was looking specifically at psychiatric features in PWS, including autism features, psychosis, and how those change over time. So that one's ended, And now we're actually working on some intervention studies, and so we're actually hoping in the next year or so to actually have some interventions for people with Prader-Willi syndrome. And towards the end, I'll talk a little bit about what those look like. They're not actually funded yet, but we're writing the proposals, and we're really interested in figuring out ways to connect people socially with Prader-Willi syndrome to actually kind of head off some of the psychiatric features that we talk about. So to date, we've seen about 245 people in these two grants with PWS, and we've had over 645 visits. So some of our families we've seen 5, 6, 7 times, and some of our families we've actually followed for over 20 years. So the young man you see in the frame is actually somebody that I saw for the first time in 1996. And over the years, I mean, I still see him probably once or twice a month. He's actually a local guy. And so it's really cool to watch people grow and change over time. And we follow people as young as 4 all the way up through 66 all over the U.S. and Canada. So as far as the people that we see, we have 245 individuals with PWS. The mean age is about 16. We do see kids obviously pretty young. The gender is really evenly split, about 50%, 51% female and 48% male. You'll see that we see a lot of people with deletion, 145, but even more importantly, we see a lot of people with UPD. A lot of families are really interested about how we can help their kid with UPD with some of the psychiatric features and behavioral problems. And we also have 7 people with an imprinting defect, and so we actually have a pretty good number of people with imprinting defect. It's not many, but if it's less than 5%, you can imagine that even 7, and we'll talk a little bit about what we know about imprinting defects. So if one of you have a child with that or you see somebody with that, they're an interesting group in the way that they actually kind of cluster as far as some of the psychiatric features. The step that we do is we ask questionnaires for families. We ask things about, there's a thing called the CBCL. It's the Child Behavior Checklist. It looks at things like externalizing behavior, internalizing behavior. The hyperphagia questionnaire is a 13-item questionnaire that talks about things like taking food, talking about food, having a lot of like real rigid things about food, when it's served, what's going to happen with it, that kind of stuff. And we're really interested in, figuring out when hyperphagia emerges and does it change over time? Does it get better? And it's one of those things that a lot of the drug companies have adapted in some ways to actually be as an endpoint for some of the clinical trials that are going on now, looking specifically at drugs that target hyperphagia. The Y box is actually the Yale-Brown Obsessive Compulsive Scale, and it's actually looking really specifically at obsessive compulsive features, and I'm going to talk a little bit about that. We do an interview with the parents looking at repetitive behaviors. That's stuff like people who rub their hands together, people who line up things, people who hoard things, collect things, all those kinds of behaviors. There's actually almost about 80 items that we collect information on, looking at how things change and severity and how much it affects family. The Kitty SADS is actually a psychiatric interview, and it's looking specifically at depression, anxiety, obsessions, all sorts of things that meet criteria for psychiatric disorders. A lot of people use a lot of these behavioral features and terms kind of interchangeably. We want to really get good at figuring out what we're talking about and using kind of common language so that as professionals, we're looking at targeting the right behaviors and not focusing on things that people may say is true about Prader-Willi syndrome, which may not be. And the prodromal symptoms, the scale of prodromal symptoms, is actually a questionnaire looking specifically at some of those odd, concerning behaviors that happen before people become psychotic. Disorganization, problems with attention, problems with like kind of trailing off in the middle of a conversation, any kinds of like, auditory, any kinds of hallucinations that we might see with people who are becoming psychotic, those kinds of things. We look at current medications. We look at past medications, which either may have been discontinued because they didn't work so well and things like that. And then we also do some stuff with the actual kid. We look at intelligence, we get height, weight, we look at EEG, specifically at memory, what they kind of look at pictures of food, things like that. We look at visual motor skills, things that they're good at, things like puzzles. We do that as well, just to kind of get an idea of how people do over time and what their strengths are, not just their weaknesses. Because for most parents, they're well aware of what their kids' weaknesses are. The often asked questions that people ask me is about life expectancy. Again, it used to be about 25 years, but right now it can be average if weight and food access are maintained. And so we have adults that we follow that are in their 50s and even 60s now who are in incredibly good shape as far as being able to live, with supports, but being able to manage their health really well with people helping them out. People often ask about living independently. I will say that all people with Prader-Willi need some level of support. It really depends on the person. I have people who live with parents. I have people who live in group homes. I have people who live with parents in their own apartment. I have a few people that actually are married or are in college. So the deal is it all depends on what level of support that they need. And so I tell people we can't look at this one size fits all because it simply doesn't work. We really have to adapt the supports and services for the person with Prader-Willi syndrome. A lot of people wonder if behavior gets better as they age, and for some it gets a lot better. We have people that are living so much better and they're so much happier and more content, and they have so few behavior problems that wasn't true a few years ago. But hyperphagia is the one thing that generally doesn't get better with age. Some people definitely seem as they get older to be less preoccupied with food, less food seeking, but it's definitely not many people. So I tell people you have to just be aware that's a pretty rare thing. But we do see a few. And how does growth hormone help adults with PWS? And I'm actually going to focus a little bit in the middle about that. We have some really intriguing data about what growth hormone does for people with Prader-Willi syndrome, and it's really fascinating, and hopefully we'll get insurance companies and other people on the same page about prescribing a maintenance dose for adults with Prader-Willi syndrome. So parenting an adult with Prader-Willi syndrome can be really difficult. We do a couple of really kind of odd tasks that we ask people to do with their kid, and the people you see in this picture are actually doing something called the birthday party task. What we do is we have all sorts of different foods, some healthy, some not so healthy, so there's fruit and salads and things like that. There's also several different kinds of cake and pizza and, fried chicken and things like that. So we put them all around. There's about 30 some odd items that we put around the edges of this like kind of birthday party paper. And so we ask people to work with their parent and decide what they could actually have on their birthday party menu for the day that's their birthday. And so we just try to figure out how parents work together, how they direct, how much they control, how much they try to control but can't, those kinds of things. And we have some people with Prader-Willi syndrome that put on just this incredibly great meal of a salad, a fruit, a main course maybe of some sort, and even like something like a cookie, and they'll say, that's my birthday dinner. We have other people that put all 30 some odd items on there, and so they're the ones who try really hard to like get their parent to agree that all these things are completely, normal to have on your birthday, and we can have 30 items. Because it's not real food, obviously it's not detrimental, but we're really interested in how people work with their kid with Prader-Willi syndrome and how that affects the kid and also how it affects the parent, because for a lot of people it's very stressful dealing with food issues, and so this is one of those tasks that's really interesting to see how people work together. We also interview the parent separately from the child, so you can tell me anything, and then I interview your child separately from you, and we ask some of the same things and really try to focus on those psychiatric features that parents may be concerned about but not really sure if these things are problems yet. So as far as us, the adults with Prader-Willi syndrome, I'm going to talk about cognitive functioning, adaptive functioning. Adaptive functioning is the things you can do on your own. So telling time, being able to do all sorts of kind of social things, being able to kind of do like clean your room, load the dishwasher, all those kinds of things. We're really interested in what kinds of skills people have. Maladaptive behavior, those things that we find really troubling in Prader-Willi syndrome. Hyperphagia, everyone knows about, and food seeking, and then things like anxiety, depression, and looking specifically at psychosis. And we do a pretty significant interview with the parent, and then we do it as well with the child, just trying to get an idea of what's going on. We also do something called the ADOS, which is actually a autism diagnostic interview, and what we do is we actually spend about an hour doing that with each child and an adult that we see to figure out how many autistic features they have, if any, and how significantly they're impaired from those things. We also look at independence and family issues. So what kinds of things are going on? A lot of parents often think that whatever's going on has everything to do with Prader-Willi syndrome and nothing to do with anything else. But if there are issues with other siblings or school issues or parenting issues, we're really interested in how those affect people. And often when people come to see us, they'll be really focused on their kid's Prader-Willi syndrome, and I'll turn it around and make it totally about what's going on with their family and how we can work on those issues to make the kid with Prader-Willi syndrome. So sorry about that. Am I still here? Hello? Dang it.
Yes, you're still on.
Okay, so sorry. I can't believe somebody's calling me this late, and I'm sorry, I can't turn off my phone because that's what my speaker is. But anyway, we're looking specifically at family stress and functioning. So what kinds of things are going on with family, and then really specifically at psychiatric medications to figure out what's going on with families. So as far as cognition goes, the average IQ everyone talks about is between 65 and 70. We have people that are as low as 40s all the way up through 125. So this idea of average is great, except there are a lot of people that are much lower or much higher than that. So I think we have to really know the person that we're talking about and realize that they have some relative strengths in things like visual spatial things, reading, and then some weaknesses in maybe auditory short-term memory. A lot of parents say when I talk to my child, they don't seem to remember things. It can maybe be selective, and it can also be attention, but they don't remember things that are much more than 1 or 2 step commands. It's just too much information. So it's really important the way you present information to them, and visually is really the way to go. We use a lot of visual schedules and things like that so they can refer back to it. They don't have to rely on me saying it once and then remembering it. So I think that's really important to realize what their strengths are, and to know that the interference from food seeking and maladaptive behaviors can lead to a lot higher levels of care. We have folks who have average IQs, but obviously they can't live alone because they continue to have issues with food seeking or temper tantrums and getting along with people. So it's really important to know that looking at IQ or even adaptive functioning is not the only way to look at PWS. There are so many other factors that go into it. So some of the externalizing behaviors in PWS, and for those of you who work with them, all these will be very familiar to you, things like temper tantrums, physical aggression, which some people do, verbal aggression, which a lot more people do, things like stubbornness and oppositional behavior are really common in PWS. You know, you say this guy is blue, they say no, it's not. So they just have to be disagreeable. And I tell people it's really important how you approach certain things, because giving them the opportunity to oppose you or argue with you is sometimes the worst way to actually deal with them. Being much more directive and just kind of saying things is a better way than actually asking them questions that they're going to be negative to. Skin picking, pretty common. Repetitive behaviors, sensory behaviors. We have a lot of people who rub things, touch things, do all sorts of things that are very sensory kinds of things. Rubbing string, playing with things. You know, we have people who unravel socks and mittens and things like that. Also things like impulsive and inattentive behaviors. It's really common in PWS, and I'm going to talk a little bit about prevalence rates of some of these things, like how common they are, because we talk so much about the common physical and kinds of behavioral features, but there's some things that we don't think about that really do impact people with Prader-Willi syndrome. Irritability and annoyance is a really common part of PWS, where they just don't like how things are. They think the world should go a certain way, and it generally doesn't. So those are the kind of external things, the kinds of behaviors that we can actually kind of see and record. Some of the internalizing behaviors are things like anxiety, which we can't really know how anxious somebody is, but you can tell a lot of times by questions and, you know, really insistence on things being a certain way, rigidity, perseverative thoughts. Generally, people with Prader-Willi syndrome have really poor insight. They're really great at telling everyone else what they're doing wrong, but they have a really hard time understanding their part in it. And they often worry about scheduled events, when things are going to happen, what's going to happen next, and or things going to go just as kind of as planned. And that obviously is really hard in our everyday world to make that happen. Also really easily slighted. If somebody does something that hurts their feelings, or they feel like they're, you know, kind of being made fun of, they can really hold a grudge. So I think it's really important to know that sometimes if you have a really negative experience with somebody with Prader-Willi syndrome, they will hold a grudge and they have a hard time forgiving you. So how do these features relate to things like ASD? So some of the same things that are part of autism are things like anxiety, insistence on sameness, and we're going to talk a little bit how PWS autism features look versus people who have just autism, because there is some difference, and I think it's really important to talk about what that is so that we don't say that everybody with Prader-Willi has some level of autistic features, because they certainly don't. So autism and PWS, our colleagues across the ocean have said stuff like people with UPD are much more likely to have severe affective disorder and psychosis. They're more likely to have ASD symptoms. That's been kind of found over and over. And it's probably very much related to an overexpression of maternally imprinted genes in that 15q1113 region. And that probably psychosis, there's some risk factors and there's also symptoms. And I will say that for people who have psychotic features with Prader-Willi syndrome, they often have more than one episode, so it comes back. And so it's really important to know that it's not a kind of a one and done kind of thing. They can come back. It's important to know what that looks like. It's also important to know that medications can make a big difference in keeping them at bay and keeping them from happening again. So for us, it's kind of assessing symptoms and making observations and caregiver reports. We need to be able to use the same language to describe these things so that we're talking about the same thing. So the overlap of ASD and PWS are things like repetitive behaviors. That doesn't shock anyone here. But anxiety over novel situations. People with PWS can react really strongly to novel situations. Even though it may be similar to something they've already experienced, they may have a really negative reaction. Restricted interest, and it's not just about food. I have people who want to talk about Twilight and, Harry Potter, and it just becomes very obsessive. And so if I try to change the subject or talk about something kind of related, they will go right back to it. So for some of you, you may know that your child has some pretty significant restricted interest, and that's pretty common in autism as well. Poor social cues. Reading what other people are doing. When you yawn, maybe you're tired of listening to this conversation. If you look away, maybe you're tired of having this conversation. They don't read social cues. They also don't take perspective or have insight about other people's feelings and thoughts. And so often they feel like whatever they're thinking and feeling is what everyone else is feeling. And so that makes it really hard for them to understand that if you like something, that somebody else may not like it. And also that's really true of their behavior. If they have a behavior problem, they don't often see that any part of it, they have any part of it, the interaction. They often blame others for doing different things, and some of that may be true, but they don't actually have any ability to see their part in it. Scripted speech, lots of questions. They have to ask the same thing over and over. They need to follow schedules. They want routines to be in place. And, one lady described it as being like the movie Groundhog Day with Bill Murray. She said, my daughter would like it to be that day every single day. And so I think it's really important for us to know that that's how they see the world, as things should be a certain way every day, time in and time out. And so for us, it's trying to figure out ways to actually manage those things so that they don't become so rigid. Sensory issues like textures, touch, and smell. We have people who like to touch and smell things, and I'm not talking about food. They'll smell my hand, they'll touch my pen and smell that, things like that. Some things that people don't talk much about in PWS, but there's definitely some sensory issues that seem to be pretty common. They're much more common in childhood, and they definitely kind of get lessened as people become teenagers and adults. But they don't always go away. Sometimes they just transform into new kinds of things. And so I tell people the energy is always there. Sometimes it actually changes what it does. So the whole thing is looking at assessment and observations. I'm going to talk a little bit about that. So autism and PWS really looks different. I will tell you it's more common in people with UPD, and if you're a boy, which is true in people who have autism already, poor social and communication skills, restricted interest, rigidity and repetitive behavior, sensory issues, poor eye contact, and they really lack empathy and ability to read social cues. People often talk about their child with Prader-Willi syndrome as having a real inability to be empathic or care about others. And so I tell people a lot of that is they just look at it as how it relates to me. So if it doesn't relate to them directly, they're not often interested. And even when they are interested, it doesn't seem to be the same way that we often think about things, where we talk about being able to kind of like change what we do and able to read social cues based on what people are doing. But we've also found people with deletions and imprinting mutations who also have autism. So it's not just people with UPD. It's really important for people to know that you can have a kid with a deletion or imprinting mutation with autism. Those who have the classic autistic features, PWS is seriously overshadowed. So sometimes they have a lot less food issues. Sometimes they have a lot less of the kinds of classic PWS things. And so most people don't have true ASD. It's pretty rare. Actually, we're going to be publishing a paper that's about to come out, and it's about 12% out of our sample, which is not many. So it's not nearly as many as some of these other studies have suggested. But if you really look at just cutoff scores, a lot more people hit cutoff scores. But if you look at true ASD criteria, it's not as many people. So 12% is about the, what we think in our sample of people who have autistic diagnosis. And again, we do use the gold standard and multiple raters to get that. So it's not just me deciding that. It's somebody watching the film after I say, I think this kid may have it, so that we can actually make sure there's a consensus about that. Obsessive compulsive disorder is something that people talk a lot about in PWS, but I will say there's no gender changes, there's no gender differences, there's no subtype differences, there's no age, no BMI, none of those things matter for people who have OCD. But they do have more hyperphagic symptoms if they meet criteria. So people who are OCD, which means very obsessive, very rigid about things, they often have more hyperphagia things. I tell people it's really important to see how these behaviors not only affect the person, but more importantly, their family. If I want to do something over and over and over again and people let me, well, I may not think it's a problem at all. But if you're a parent and you're having to do things over and over or take lots of time to like pack up things or do things a certain way, then for you it could be a huge problem. So we ask parents specifically about those OCD symptoms because people with Prader-Willi syndrome often say, nope, it's not a problem for me. So high rates of compulsive behaviors aren't related to food. People talk a lot about them being, but they're really not. They just seem to have these really rigid kinds of things that they do. And so some of the things they do are hoarding, paper, toiletries, stuff, books, videotapes. It really doesn't matter. And they really want to keep them and they don't want to let them go. And so parents often say they have to sneak into their kids' room when they're not there to get rid of stuff. And they can't get rid of too much. It has to be a little bit at a time. But that's 80% of our group that hoards to some degree. Arranging in order by color, size, shape. People sort beads. They stack up crayons. They do all sorts of things like that. And they spend a lot of time doing it. Symmetry, exactness, having to have things just a certain way. People who cut, they'll just sometimes just cut things and they'll cut them over and over and over until they're just right, or excessive erasing and rewriting. That is really common in school-age kids, but it definitely goes away as people get older. Long showers, using up all the hot water. All of you will go, oh yeah, my kid uses, a whole Costco thing of shampoo or body wash, but whatever they do, they seem to do it to excess. And so I've had a couple people who will literally use a bottle of shampoo in a couple of days because they just kind of shampoo over and over and over. And so those are things that I think tell people they really need to watch for. And there's all sorts of ways, from even giving them a Dixie cup, with shampoo in it so they don't use it all. And it also keeps showers shorter. And if you need to turn off the hot water, then you need to do it because they generally don't like to stop anything that they're doing. Some of them are food related. Some of them have the food not touching on the plate. They have to eat in a certain order. Other people are kind of messy and it's not an issue. And then some people literally deconstruct things from sandwiches to casserole so they eat all of one thing before they go to the next thing. So there's some really interesting food-related rituals there. Skin picking and hair pulling are in that same category. We're not really sure it's exactly the same thing, but it's grouped together. So hair pulling is pretty uncommon, but skin picking and Prader-Willi syndrome is extremely common. And for people who do it, they seem to do it a lot and more in times of anxiety or great stress or changes in environment. So how does hyperphagia relate to anxiety? Some people say it's all about the food. Well, I tell people it's not all about the food. We have people who sometimes don't have any hyperphagic symptoms, but they have lots of OCD symptoms. So we really do need to know more about that, and we also need to figure out more about what we can do to help some of these things, not just medication, but environmental things that we can do that can make anxiety better. Because I've actually had kids who've been in some clinical trials where hyperphagia gets markedly better, but what's interesting is sometimes the anxiety doesn't always go away. So there's definitely something to having Prader-Willi syndrome that makes you more anxious. So some of the compulsions we see, some of the repetitive stuff, we have some really odd things with pregnancy, being in love with people, obsessed with others. If you guys have teenagers and young adults, you'll often find that they're obsessed with people. They don't just call them once, they call them 100 times. That, have a young lady who constantly thinks she's pregnant and she tells complete strangers that she is, that kind of stuff. We're really wondering if some of these things may turn into something else, like psychosis. And for some people, it definitely seems to be a case where they become more and more obsessed with a thing, and it gets weirder and weirder until it eventually becomes something that looks like psychosis. So I think we have to really kind of get a baseline for some of these behaviors and figure out when they change. Some of them are pretty difficult to curtail, but there's definitely strategies, and I'll talk a little bit about some of the strategies that work well for controlling some of the compulsions. Changes in environment, anxiety, too much time on your hands, or being alone are huge increases in compulsions. Having not a lot of structured time means that I'm going to do a lot of things kind of over and over and over to kind of structure that time. So it's really important that they have lots of structure. We can't let them always make good choices and use their time wisely. So sometimes it's really important for us to impose structure so that they can manage the anxiety. Medications like Celexa can really help. Doesn't do everything and it doesn't fix it all, but it does make it better. And then sometimes we can really transform them creatively. I have a young lady whose mom was really, she spent a lot of time skin picking and doing other kinds of really kind of self-harm things that were really, taking up a lot of time. Well, the mom gave her a pair of crochet hooks and got her to start crocheting. And so Catherine got really good at that and became, just really just like this, became really into this and would do this for hours and hours and hours a day and started crocheting baby blankets and lap blankets for soldiers and really took something that could be really negative and turned it into a real positive. So I've had parents who've really done an amazing job of taking something negative and really doing something positive with it. So I think it's important to know that we can make some of these things better. What helps? Cueing, timers. You can only do it so many times. You can only do it this many times or this time of day. Limits on how long you can talk about a topic. Validate the feeling and then move on. Helping them go to timeout for cooling down. And I tell people, don't call it timeout. Just say, you need to chill out or go to your relaxing place or whatever you want to call it. Being proactive and not reactive, it really is important that we don't get bent out of shape about these things, because when we react, the behavior becomes so much worse. So it's really important to be very calm and always think ahead of what's going to happen next. If we can actually look at some medications and then some behavioral approaches, we can do a lot to help some of these, anxious behaviors. Being socially connected, having some kind of job, it doesn't have to be a paid job, but a volunteer job, recreational, spiritual activities, anything that keeps them involved in the community is huge, and we have to really think about that more for people as they become adults. We cannot assume that they will find these opportunities, because as they become adults, there's fewer and fewer opportunities for them. And even people who are like applied behavior analysts can actually help us figure out ways to kind of help with some of these repetitive behaviors and kind of keeping them at bay. So some of the treatment implications, those with deletions are more likely to have skin picking, more likely to have tantrums. Those with UPD are likely to have higher verbal skills, but poor visual spatial functioning. I always say they kind of talk the talk, but they can't walk the walk. So they sound very insightful and they sound really amazing, but then they just can't really follow it up with their behavior or just this idea that they really understand things. So often people with UPD will nod and smile at you, and they seem like they really know what you're talking about, but sometimes they have no idea. So it really is important to know that the higher verbal skills are in expressive language, but they're not always in receptive and really just general social understanding. Young adults with UPD are much more prone to psychotic episodes, and if you have ASD, you're obviously more likely to have some of those kinds of things as you get to be an adult. They don't go away. They might get a little bit better, but they don't go completely away. And again, we know very little about imprinting defects or translocations, but I will say that we've really taken a hard look at our people who have imprinting defects. They actually have more psychiatric features than those with UPD. So the idea that we don't know much about them, I think we really need to be studying people with imprinting defects, because they seem to have more psychiatric features than those with UPD, and people with UPD seem to have more psychiatric features than those with deletion. So this idea is that there's something different. So the idea that everybody with Prader-Willi syndrome is similar or the same, I always ask people what their subtype is, because that really helps me figure out what specific symptoms we need to be talking about and not waste a lot of time talking about things that your kids don't do. So as far as some of the things like ADHD, almost 40% of our boys meet criteria for ADHD. That's a lot of people with attention issues. So that staying focused on a task, being able to follow through, being able to finish things, those are all issues for people with Prader-Willi syndrome. Again, some of these issues get better as they get older, but again, they don't necessarily go away. So I tell people attention can be a huge issue, but stimulants and some of the other things that we think about working for ADHD are not generally good options for people with Prader-Willi syndrome, because they can make them more anxious, and they can also have some pretty significant side effects. So it's just important to know that there's some other kinds of environmental things that we can do to help people with Prader-Willi syndrome with ADHD. Motor and vocal tics. Again, almost 30% of the people in this study actually meet criteria. A lot more of them are likely to be males than females, lower age. So you're more likely to have a motor or vocal tic if you're younger, and your BMI is actually lower if you have a motor or vocal tic. I'm going to talk a little bit about what motor and vocal tics are, because people often think, my kid doesn't have that. They don't do any of those things, but you will find that they repeat words and phrases and sounds kind of over and over. And so we have a lot of people with Prader-Willi syndrome who do actually have motor and vocal tics. So parents don't recognize them, neither do most professionals. We don't know a lot to do about them, but we can actually help redirect some of that energy. So again, that's a pretty high number of people with it. Sorry about all the sirens. Sadly, my office is very close to the ambulance bay, and apparently it's a busy night here. Psychosis. People are saying 80–90% of people with UPD have psychosis. We saw several people who have psychosis who are not UPD. So it's really important to know you can have a deletion and have psychosis. So we haven't had a ton of people who've actually had active psychosis while they were here. Some have had it in the past and it's fully resolved. Some have actually had some where it's partially resolved. They're better, but not completely. If you have ASD or autistic-like features, for some reason that your baseline seems to be at a different kind of set point than other people with PWS. So I tell people those odd thoughts, those are more common with people with autistic features, and they don't seem to go away even when true psychotic stuff is actually gone. Medications and changes in the environment can be really important. Things like Risperdal work well, Depakote, some SSRIs work well. They just have to be managed well. You can't really change the psychotic thoughts and hallucinations without medication. So when people tell me that they're hoping, that they're going to do all these things that are going to make a difference, those people are the ones who are most likely to have relapses. So it's really important to get them on the right medicine and to do that in a quick way. It occurs in late teen years, sometimes early 20s, definitely precipitated by stress. And I tell people it's not the same stress we think of. Loss of a friend, loss of a boyfriend, girlfriend, diet, school, home changes, end of school. That is one of the biggest losses. When people get out of school and their structure and their day is kind of like completely open and unstructured, it's a huge issue. And it's a loss for them of social stuff, of structure, of knowing what the day is going to hold, and they're engaged and they're active. Once people become psychotic, we're seeing it more and more frequently. It looks disorganized, changes in sleep. They're not sleeping well, which is not common in PWS. They're not eating as well. Their thinking is becoming very, very odd. They become obsessed with people. They become obsessed with ideas, sometimes that they're ill or someone else is ill. It gets bigger and bigger until eventually it just becomes it takes up all of their time. So I tell people they need to be on the lookout and monitor for these symptoms, especially when stressors occur. It's kind of like a perfect storm. It's really important to know that when things happen all at once, you have to act quickly, be relentless. If you think something's going on, don't let somebody tell you this is PWS, because often it's not. And we have people who are under psychiatric care who are psychotic, and people have just told their parents, well, that's just PWS. If something is different, don't hesitate to act. Trust your gut, look for changes, don't chalk it up. Look for losses of pets, losses of friends, any other stressor, and know that having schedules and consistency can help a lot for recovery. Don't let your kid decide what they want to do all day. You help them decide, get on a schedule, sleep, eat, do things regularly, and do things that are fun, because if you're sitting at home, it cannot help just being alone and isolated. Again, you often need supervision with other people, watching them, outside help. If your kid does something that's dangerous or unpredictable, you may have to go to a psychiatric hospital. It's not an optimal thing for people with Prader-Willi syndrome because of the food issues, but if your child is not safe, you cannot protect them, and it is important to know if they're becoming to the point where you're worried they're going to hurt themselves or somebody else, that you get help, even if it's sitting in the ER all night. So you have to do whatever it takes to keep your kids safe. The baseline is always disorganized features. I tell people we are seeing it more and more frequently where their thoughts are kind of odd. They talk to people who maybe are magical, like imaginary friends, things like that. And as an adult with Prader-Willi, that's pretty odd. Kids will often do that, but not so much as an adult. But, disorganized features, changes in sleeping, eating. Then you add those negative symptoms. They don't seem to enjoy things. They seem to be more isolated. They're very much more withdrawn. And then if you add stress, you get the positive symptoms. I hear people who are talking to me that aren't really there. I hear, I see maybe, ghosts. A lot of people talk about people trying to break into their house, or worries about really odd things like being attacked, even though it's never happened. So those kinds of things are some of the positive symptoms. And with people with intellectual disabilities, it's really difficult to figure out if they're truly hallucinating. So I just tell people, if things seem weird to you and your kid talks about things like that, do not disregard it. It is sometimes very serious. Anxiety, again, is pretty common in children and adults with Prader-Willi syndrome. Sometimes it's just about everything, but sometimes it's about a specific thing. So I tell people, when environmental changes, when you've done everything environmentally but it's still not making a huge difference, then sometimes you have to look at medications, some to consider like Celexa and Lexapro, or watch out to some of the odd symptoms. If you have UPD or imprinting mutations, sometimes you have an odd reaction to medications that work fairly well for other folks. The dosage really matters, so low doses, low doses are the way to go in this population, and not to over-medicate. So anxiety sometimes looks very different in this population. You just have to kind of know what you're looking for and really stay away from, practitioners who want to keep over-medicating or keep upping a dose. We find that sometimes the very lowest is an eighth, a fifth of a normal dose is a great amount for people to actually kind of help with some of the anxiety. It doesn't fix everything, but it makes things more tolerable, and so it's really important to know that low doses and going very slowly and documenting things are really the way to go in this population. Don't over-medicate. Depression's pretty uncommon in this group, so you would think if you have a lot of anxiety you'd be depressed, but that's definitely not true. It's only about 8%. It's true for people who are older and for people who are actually heavier. So we don't know if it's because, you know, they're heavier. I kind of doubt it, but there's definitely something about having a higher BMI if you're depressed. So I'll talk a little bit about what other kinds of things are risk factors. So if you're a girl, you're more likely to become depressed, higher cognitive functioning, those with fewer social connections, and those with a family history of depression. So I tell parents, if you have a family history of depression, it's really important to tell people because that gives you an additional kind of risk factor for somebody with Prader-Willi syndrome. And again, depression does not look like it does in anyone else. They're not sitting around feeling hopeless and sad and, you know, just feeling guilty. They're irritable. They're annoyed. They don't have any motivation to do anything. They have a lot of displaced aggression. They'll be really quiet, and all of a sudden they'll be screaming at somebody. Sleep changes or more repetitive behavior. So I tell people, if your kid starts doing these things, realize it's not typical looking in PWS, so we have to really be on the lookout. Some people, sadly, have been depressed for years when I see them, and I can't believe that no one has actually caught some of these things. So irritability is one of the biggest indicators of depression in PWS, and it needs to be treated because it does not go away. As people get older, what we're seeing is there's definitely some mellowing out of some of these symptoms. And so for people who are in their 20s, if your child is in their 20s, this is a really hard decade for you, I'll be really honest. And so teen, you know, separation and trying to be more kind of independent, it kind of shifts back to the 20s. So that's really important to know. But there's definitely a remarkable drop. Once people get past their 20s or even mid-20s, we're seeing a big change in all sorts of like maladaptive behaviors. As far as subtype differences, people who have a deletion more likely to have those things happen. People with UPD, little less likely to have that happen, but they actually continue to get some of these skills as they get older. And so I think it's really important to know that, you know, there's some different subtype differences, but a lot of it's an individual child. So you just have to kind of know that when your kid is having fewer and fewer of these behavior problems, you may be hitting that mellowing part. A lot of people don't really think about the family and social aspects of PWS, but it is so important to have them be a part of something bigger than ourselves, something they love. This young man loves monster trucks, and he goes to all the rallies, and he loves doing it. But if it's volunteering at a pet shelter, if it's, you know, helping out at a church, if it's, you know, doing whatever, they need to have something bigger than them. And it's very important as a family to help support that because those are the people who are most isolated, the ones who don't do anything that's bigger than them. So school, family, sports, activities, volunteering, everything like that keeps us healthy. We have to realize that for people with disabilities and people with Prader-Willi syndrome, being busy and engaged makes a huge difference on risk factors for psychiatric issues in PWS. So don't think, well, we can't do that because there's food involved or whatever. You really have to find ways to get them involved and engaged and supervised, but not to the absolute, you know, just not doing anything that's fun or that they enjoy doing. So I'm going to talk a little bit about growth hormone, and I'll actually kind of buzz through some of these slides because I know we don't have a ton of time before we start taking questions. But people who are adults with growth hormone, we have found that they actually help. Growth hormone, if they actually can stay on it, even if it's a low maintenance dose, helps cognition, physical functioning, stamina, adaptability, and ability to care for yourself. So those who actually go on growth hormone, even as adults, have huge changes in all sorts of other things. A lot of sadly, insurance companies don't want to cover it, but what we do see is that if we can keep them on a maintenance dose, it actually changes so many things, and I'm going to show you what it does change. Composite IQ, people on the top are the orange, people on the bottom are the gray, so the orange is growth hormone treated, the people in the gray are not. Some of the IQs are, you know, 7, 10 points difference. That's really amazing. So that's just what the difference between our growth hormone is. So here we have adaptive behavior. That's being able to take care of yourself. Look at the changes in people who are on growth hormone versus people who are not. Again, taking care of yourself, that's a huge difference. I mean, it's totally significant. And we actually control for SES and all those other things. So we actually found a way to take out all the other things that would affect these scores and just look specifically at growth hormone. BMI. Again, as you get older, BMI goes up, but it definitely makes a big difference. Look at the people in that first group, the type 1. There's a 14-point difference in BMI from that type 1. So even though it definitely goes up as they get older, it keeps BMI, to me, at a much more manageable range. Doesn't seem to change much for hyperphagia. I tell people growth hormone doesn't change people's eating, may early on, but it definitely doesn't as people get older. So doesn't do that. So interventions, I think we have to really know what you intervene with and when you do it. So don't have, you have to have a plan in advance. You can't just kind of wing it as you go. Looking at things like placement choices, like where are they going to live, what's going to happen to them. We have a lot of parents who say stuff like, well, he's going to live with a sibling or things like that. Sometimes they don't actually talk to the sibling about that, but it's really important to have a plan and know where your child's going to be. They can't be completely independent, but they can be much more independent if we really focus on what skills they need to have to be independent. Look at your family. They're part of your family, part of a community, so we have to figure out, looking at your family, what would be the best way to help and support your child, because every situation is different. There's not enough PWS-specific group homes, but we have a lot of people who live in places that aren't PWS-specific, and they do fairly well. So you just have to find the right fit, and if it's not the right fit, you will know, because all the behavior issues will become much more significant if it's not a good fit. I really have to focus on parents taking care of themselves. Laugh about anything, even if it sounds nutty or whatever, but find your friends that can find humor in some of the crazy things that you do and your kid does, and find friends that are like you. Don't, they're going to have to probably be people with special needs, because they're the only people who can understand you. You have to take time to relax, sleep, and exercise. You cannot think that there's, I don't have time to do anything fun, because if you don't, you will find yourself becoming more and more depressed and more unable to take care of your child. And it's a marathon, not a sprint. So you really do have to pace yourself. You cannot not take care of yourself at the expense of your child, because we have parents who are getting, all sorts of horrible things happening to them health-wise, and they can't take care of their kids. So you have to take care of you. It's a lot like that oxygen mask dropping from the plane. They tell you to put it on yourself before you put it on your child, and it's just imperative to do that. And when parents say they can't, then you need to figure out a better support system or other people or whatever. And sometimes you just have to sometimes say, I'm going to take this time for me, and good luck to the rest of you, and really be selfish about it, because if you're not, you will find that it's just really difficult to kind of stay in the race. We've seen some of the oldest adults with PWS. I love this group of girls. We're all from New Jersey, and they're doing really well physically, mentally, but it is all because of where they live and what they're doing. These girls are engaged, they're happy, they have a great support system, and I just think it's really important for people to know that it's all about environment and support and social connectedness. If your kid is not connected socially in some way, doesn't matter what it is, then they're really not going to be doing as well as they get older. So the only kind of independence you can have is when there's a community support system or some system where people love and take care of your child, and it's not just you. So some of the adult challenges are things like finding a girlfriend or living independently. This young man is so interesting because he wants to do both of those things. And so we talk a little bit about, realistic expectations and not. And so things like finding a girlfriend can be realistic. But, I tell people they have to have some kind of outside the box ideas of what a girlfriend would be like, and really importantly, what would be an appropriate relationship for your child with Prader-Willi syndrome. And you have to help them navigate that. They don't have a great idea of what that would be, and often the people they're most interested in are completely inappropriate for them. But also living independently, they can do that to some degree, but it's not completely independent. So when they tell me they want to move out and live in their own apartment, I say, what about the possibility of living with some roommates who, who maybe like you, with somebody who could kind of help you out? And they're like, oh, well, that sounds okay. Well, that's residential living, and that's a great thing. So I don't really call them even group homes anymore. It's really important to kind of let them see it as being as independent as they could possibly be. So can they live on their own? Again, don't follow anybody with PWS living entirely on their own. Some live semi-independently and have some help. The biggest predictor of who's going to be most independent is lack of maladaptive behavior. If you have a lot of behavior problems, you're not going to be able to live independently. It's not really even cognitive ability. And those parents who are working on things like doing laundry, chores, managing their time, all those things that we talk about adaptive behavior, those kids are most likely to live more independently. So Those are the things we really need to be focusing. Algebra will not help your kid, but figuring out ways to kind of manage their time, self-control, all those things are really important. You have to really focus on them, and you have to teach them. They do not learn it on their own. Things like, as they become older, money access, food access, could they have a job, could they be a volunteer somewhere, what residential services you have, being part of a religious or spiritual life. If that's important for your child, then you need to find a way to make that happen. And sometimes even in churches and stuff, they can find ways to be a part of that community. So it's important to find something that's supervised, but not necessarily cuts off all the things that are important to them. Friendship, social outlets. We do something here at the Kennedy Center twice a year with our PWS families, and we do like puzzles. We do a walk, and then everybody comes and does puzzles, and we have 30 of them, and they're all these kids and adults with Prader-Willi syndrome just putting them together, and they absolutely love that feeling of camaraderie and connection, and they get along so well for that 4 hours that we do that. Building exercise and leisure activities are also really important. But don't forget, you have to have fun, exercise, and leisure as part of your life. I'm not going to talk much about the residential services, but you have to kind of look and see what they are in your area. There are a lot of states that have none. We're sadly in a state that has none. But find ways outside the box to look at making your own residential services, with your state, other people who have kids with Prader-Willi, that kind of stuff. You have to really be creative. There's very few services for very many people. So continue to change as things change. Parent towards independence. Focus on what your kid can do for themselves, life skills, social skills. Let others step in and help you wherever that can be. However you can have other people help you and be a part of your child's life, take some of the focus and strain off you, and it's really important to be able to do that. You have to take care of your needs, both physically and mentally. You definitely have to let go a little bit. I had a parent once who said, well, no one will ever love my child the way I do. And I said, you're right, they won't, but that's okay. If they can take care of your child and your child can have some level of independence, then that's important. So you have to trust other people and trust that, other people will do what's best for your child. Not always, but a lot of times they will. And, I tell people, you're going to have to fight like hell to get services. They do not come to you. People don't knock on your door and say, oh, there's all these great things for your child. So you will have to go and get them. So realize, access PWSA, access all the people who've done things that you need and figure out how they did them, and then try to do the same thing. I'd like to thank all of our awesome families who come to see us and who teach us all there is to know about having an adult with Prader-Willi syndrome. We really want to know what works, and this family on the picture does a great job of really maximizing their child's success and trying to minimize whatever problems he has. So I think it's really important to kind of know your child and know what works for them, and to really be creative when it comes to figuring out ways to solve some of the challenges of being an adult with Prader-Willi syndrome.
Thank you. What a wonderful presentation. We have several questions, so we'll start to dive into those.
Okay.
First parent concerned about food safety and volunteer and work environments has some funds and wants to start a small business so she could have that food security for her child. Do you have any suggestions in that regard?
I think I tell people, find out what your kid likes. So a lot of them like animals and things like that, so dog walking, whatever. I think you have to let everyone know who's involved with your child that they will take food, they will take money, that those things are just things that somebody has to kind of watch for. So, you try to supervise as much as you can and find people who are willing to work with you. So I have a few people who do jewelry, who make greeting cards. There's just as many different ways to actually have a job. You just have to know what your kid likes and find a way to keep them safe.
Secondly, what is the best way to get your child to leave where they currently are when they are in a tantrum and have become a crying, wailing blob of weight?
Yeah, that's an interesting one. So I tell people, try not to get it to that point, but, if it does get to that point, I have actually stepped over people or around people and said, well, I'm going to go do, and I try to make it something fun, because obviously there's no way to get them to leave if you don't. We're going to go see so-and-so's dog, whatever, and say, I sure would love for you to go with me. Doesn't work every time, but it definitely works more time than others. And sometimes you just have to let them get through it. So it's so important to, when you see a tantrum starting, to try to redirect that energy before it becomes that, because once they're dead weight, there is no moving them. There is no like getting them out of that place. So it's really trying to see it before it happens. And if you need to, don't fall victim to that. Don't actually, get yourself trying to talk them out of it or giving in to stuff, because that's exactly what they're trying to get out of you at that point.
How common is enuresis in Prader-Willi syndrome?
I don't know. I would say probably more common than we think. And I have quite a few adult boys that become enuretic as they've gotten older. So I would say probably more common than we think. I think a lot of people don't talk about it. But I think that maybe is a better question for maybe Jennifer Miller or somebody else who's a doctor. But I mean, we definitely see it. And we also see people who are enuretic for behavioral reasons. I have a couple people who pee on things out of spite. So if somebody makes them mad, they go in their sister's closet and they pee all over her shoes, and they go, oh, I didn't mean to. So you have to know, is there some gain in there? And if somebody's doing it in a certain place and it's not, then that's completely different. And we have people who do that. And if that's the case, you make them clean it up, they wash the sheets, they do whatever they need to make amends. And usually if you do those kinds of things, they will stop doing it. So it's really important to know if it's a physical issue or it's more behavioral. And behavioral usually means it's not in the middle of the night, they're walking around the house peeing on stuff. And we have adults who do that.
Does food-seeking behavior correlate positively with IQ? If so, does that change or continue into adulthood?
It doesn't seem to correlate with IQ. So I would say that people who are smarter are kind of craftier at it. They might actually be able to hide it better or be sneakier about it, but it's definitely not. We have people who have lots of food seeking that have relatively low IQs, and we have people who are pretty high functioning and have pretty big food seeking. So I would say not related. But if they're smarter, they are going to be able to come up with all sorts of things, like even opening their own credit cards to actually buy stuff like food. And so I think you just have to be aware that they might find more crafty, kind of sneakier ways to steal food.
Is there research related to sleep and its impact on behavioral issues, namely that better sleep reduces tantrums?
There's a lot of anecdotal stuff, but I would say that I don't think anybody's really looking at that. I do have a few people who had some pretty significant anxiety or tantrums and started CPAP for sleep apnea, and it definitely seemed to lessen those behavior issues. So I would say, and that's true of anybody, for anybody with ID, inadequate sleep definitely makes behavior problems worse. So I tell people getting sleep studies and following through with, CPAP or whatever you need to do so that your kid sleeps better is huge. So sleep is crucial in any way you look at it.
What can you offer in the way of a remedy, or that's not the right word, but an individual that plays with their feces?
Supervision. So I tell people, so when that kid's in the bathroom, you're sitting on the edge of the tub and it's eyes on. I mean, so you have to do that. And if they do play with it, there needs to be some kind of consequence. They lose some kind of privilege or whatever. And so if they're younger or very low functioning, sometimes there's more things going on. But if it's a recent behavior that hasn't happened in the past, then I would say it's really important for somebody to have eyes on. And you tell the kid, sorry, because this has happened, I'm going to have to watch you in the bathroom. And I have even teenagers and adults that have somebody watching them in the bathroom. Once that you do that and they know there's no ability to do that, they generally tend to stop. But it really does take some time to keep those things and reward when they don't. Like if they don't, great, let's have some kind of special treat. But if they do, there needs to be a consequence. You can't just let it go. But supervision is the biggest way, eyes on, to keep them from doing those things. It feels really intrusive, but if that's what you have to do, that's what you have to do.
Is your study currently accepting more patients?
We are not right now. We're actually looking at some intervention of like social things. We're actually thinking about doing a virtual online kind of like social community, kind of like I would tell people SimCity, so that people with PWS can interact with other people, and figuring out if that makes a difference in their ability to kind of like deal with depression, anxiety, and things like that. We want to find them a way to be connected, and we're looking specifically at late teens and early adults. So those are the people who seem to have the fewest opportunities. So we're not taking people, but be looking in the next year for actually recruiting of people to be in these virtual kinds of online communities and find ways to measure changes in psychiatric functioning and hopefully make things better for people as they become adults.
Are there any resources like your team on the West Coast?
I don't know. So I'm guessing that there's probably, I think Irvine. So there's a few people with Virginia Commodus and other people, but there's not a lot of people looking specifically at behavior. So, but I tell people I do behavioral consultation. So if you email me, I'd be glad to talk about your specific kid. We usually just set up a kind of a time to talk. We talk about what's going on. You tell me in an email what specifically you want to focus on, and we'll figure out if there's a way we can help. So maybe not, but I do think there's the ability to help consult with families and see if we can help in some way.
Okay. Are there published studies regarding the benefits of continuing growth hormone into adulthood? And there's a couple questions in this regard in terms of, and the other one, trying to get insurance companies on board with that for adults after, they feel that they're grown, finished growing.
Right. So, those are great questions. So right now there's only one, I think there's one really small study of just a few adults that somebody did, but we're actually hoping that this will be out in the next couple of months, and hopefully we can find, and it's a lot of people, it's actually 130 people. So we're hoping that insurance companies, and we're hoping that between PWSA and maybe FPWR, we can get some traction with this being the standard of care instead of just, oh, this would be really great to have that. And so it's definitely true in younger people with Prader-Willi syndrome. It's kind of a standard of care, but it's definitely not in adults. So I think we have to really make the case that there's research that backs up being on a continued maintenance dose of growth hormone as people get older. So I tell people we're hoping that we keep getting turned down saying that we don't have enough people, but 130 people with Prader-Willi syndrome is quite a few. And we have several teens and adults who've never been on growth hormones. We have a bigger group of that than probably anyone else because we're not endocrinologists, and our folks just kind of come to us wherever they are. So a lot of them have never been on growth hormone, but we have 40 and 50-year-olds who start growth hormone who show significant changes across the board. So it's a pretty amazing thing that growth hormone is as close to a treatment as we have.
This writer wonders, how common is it for an adult to refuse to maintain regular hygiene? In this case, it's a 59-year-old, and from listening to you, she believes the individual may be exhibiting psychotic symptoms. So the person is on Xanax, Abilify, Prozac, Topamax, and Depakote.
Wow. Yeah, so she's on a lot of meds, maybe not all the right ones, but what I would say is if this is a new behavior, then I would definitely look at psychotic-like features. If she's always never really brushed her teeth or hair or showered, then it may not be those things, but if it's a recent thing, and I would say in the last couple of years, then it could easily be the kind of prodromal disorganized state of PWS, and that disheveled appearance. When I see people who look disheveled and normally they are very well groomed, that's a kind of a red flag. So I tell people, if she's high functioning enough to actually talk about what she's thinking and feeling and those kinds of things, or her behavior is markedly different, then I would definitely consider looking at psychotic-like features, because it sounds like she may be exactly that.
Give suggestions on managing behavior while minimizing conflict. In the example of the teen won't turn off the TV or computer, stays up very late, leaves the house without informing parents.
I think some of it is having expectations up front. So I tell people watching TV should actually be like a scheduled activity. So it shouldn't be just like you watch whenever you want. It really should be you're going to watch a show or whatever. And I really like timers. You literally put it on top of the TV, it bings, you got to be able to hear it, because if you don't, your kid will turn it right back around, and next thing you know, they've got another hour. But, being able to look at those things and say that we have a schedule, and if they agree to follow the schedule, there's some kind of reinforcement, and if they don't, there's some kind of consequence. It doesn't have to be punishing as much as if you stay up late, if you stay up past your curfew or bedtime, then there's some activity that doesn't happen the next day. You lose your iPad, you lose your TV time, whatever. But I tell people you can't just think they're going to self-control, because they generally will not. It has to be parents doing it in an active way. And once you do it long enough, they will, be much more agreeable, but it can't be like a conflict. It literally has to be like a contract or an agreement, and the expectations have to be spelled out up front. You can never do it when they're watching TV and say, oh, now you have to turn it off, or now. It has to be all agreed on before they turn on that TV.
Do you know of any data correlated with borderline personality diagnosis as well as Prader-Willi syndrome?
I don't know anybody who has borderline personality disorder, so I will say I don't have any data, but we don't have any reason to. I mean, that's a pretty unusual diagnosis, and definitely occurs in the general population. But I think some of the extreme emotions and reactivity looks like borderline personality disorder, but I don't think it's truly borderline personality disorder. So, if other people believe that, then that may be true. But we have people who have all these odd diagnoses that people have been diagnosed with, and sometimes it really kind of it clouds the water to the point where you're not really dealing with the real issue. Does that make sense? It's like we're dealing with all these other things, and it's like, I'm not sure it really is that, because borderline personality disorder has some pretty significant things that happen to you kind of early on that kind of cause that. So having that seems kind of odd. I feel the same thing with bipolar disorder. I don't think that's really very common, if at all. So the deal is we have people who have lots of mood shifts and they're really reactive and whatever, but it doesn't look like true bipolar disorder. It's just I tell people they're angry, they're not manic. It's like there's a very different kind of like take on it. So I think it's really important to get an accurate diagnosis, and that I have never seen anybody with borderline personality disorder with Prader-Willi syndrome.
Okay, that's the same question. Our daughter, 18 years old, talks/mutters to herself a lot. Any suggestions on what might cause this and how to deal with it?
People with Prader-Willi syndrome often will kind of talk under their breath and have these like kind of completely independent conversations. It's just their way of processing what happened. So I tell people you can either say, "Are you talking to me?" and see if they'll repeat it and be like a conversation. And if they won't, you can even say, "Gosh, people look at you when you talk to yourself out in public." It won't always change it because they don't care so much about peer pressure. But sometimes when they're high functioning enough, they can actually see that keeps them from having friends or connections with other people. So I tell people, if you're talking, "Hey, are you talking to me?" "Well, who are you talking to?" and see if they say anything. And if not, say, "Well, you can do that in your room." Like, find a place where you can do it, that it's okay to do it, but maybe not out in public. And usually by the time they get to be teenagers, that gets better. But I tell people you have to kind of maybe limit it. Maybe say you can do it from this time to this time or in this situation and not. But you have to have like little limits on it and maybe kind of tighten them up as time goes by to make that less and less of a problem.
We have two questions about guardianship. One is whether you find that lots of parents become guardians of their adult children with Prader-Willi syndrome, and another is the quandary of becoming the guardian, but yet the child is fairly high functioning and wants to remain independent.
Right. So we do have a lot of people who become guardians as their kid gets older. It's really important when it comes to medical decisions and all sorts of other decisions, because if your kid with Prader-Willi can make them, they can make some really bad decisions. If they're high functioning, it's imperative that somebody actually look at their ability, like I said, open a credit card, get a job where they're in contact with food, those kinds of things. So it really is important. A lot of states have rules about how you can get guardianship, but we've actually helped several people get that based on the fact that their child will still do risky and dangerous things. So it's not so much IQ as it is their ability to kind of take care of themselves, watch out for themselves. And so in a lot of states, that is actually enough evidence for people to do that. Taking care of your child doesn't mean you take away all their decision making. So it shouldn't be that you're, lording it over them and making a big deal. It really needs to be that we want to help you make good decisions that affect your health and your life and all sorts of other things. And the only way we can do it is if the court, acknowledges it. I tell people we have adults where the psychiatrist or the physician won't talk to the parent because the parent doesn't have guardianship. So you have a kid with Prader-Willi, even though they're an adult and even though they're high functioning, making decisions about med changes and all sorts of other stuff. So it really is imperative that you look into those things in your state and figure out what you need to do. If you don't do it, you may find that your kid can actually get into some serious trouble, and it will be really difficult to get out of it because you haven't done those things. So I would say it's imperative to do it.
Do you have any suggestions to stop bedwetting in a teenager?
If they're dry during the day, a lot of it tends to be that they're really heavy sleepers. So I just tell people the same thing. no liquids after 6 o'clock or whatever time that you think, and really watch how much they're drinking. I have people who say, well, my kid's wetting the bed, but they're literally downing, glasses of water before they go to bed. Limiting water, waking them up, and I hate to tell parents to do that because it's really a hassle, but maybe you set an alarm that wakes them up and say, when you hear the alarm, you have to get up and go to the bathroom. So they go to the bathroom before they go to bed. They get up maybe once during the night, and sometimes it is parents getting them up, and I hate to do that to parents, and making sure that they go in the middle of the night, and then if they're dry in the morning, some kind of reward. They need to know that if the right thing happens at the end of the night and they're responsible for that, there needs to be something good about that. Otherwise, your kid will stop doing it. But if they do wet the bed, they need to wash the sheets and do whatever. If they can, they need to do all it entails to take care of it. Because think about it, if somebody took care of all your laundry and did all your stuff, you would never have any reason to do those things. So it's imperative that they're dry during the day, wake them up and have them go and limit their water in the afternoon.
We're going to take just a couple more questions as we're nearing the end of our allotted time. Do you deal with patients who are shameful or embarrassed to have the diagnosis of Prader-Willi syndrome?
Yeah, we do actually have some people that really feel that way. I had a young man who was saying that he felt that, he should be able to, he said, pray hard enough to get rid of this. And so he kept saying, I just don't want to have this. And so, I think it's really important to realize that everybody has something. So I tell people, I have no sense of direction. I can't tell left from right, still can't, and I'm 50 some odd years old. So the deal is everybody has something they're not good at. So pointing those things out is really important, and realizing everybody has something. But it's really important to realize that, having Prader-Willi, though there's a lot of bad things, I think you really have to focus on some of the good things. Focus on what your child is good at, what they love, who loves them, who they make happy, those kinds of things. And then it's a lot less shameful. But it's a process, and so when your kid says that, you have to hear it, but also help redirect and reframe it into something positive, because there are actually a lot worse things to have than Prader-Willi syndrome.
Have you ever seen a person with Prader-Willi syndrome who is transgender? Our daughter was born as our son, wondering how unusual that is.
I've heard of that a couple of times, and so I think because of the issues with the external genitalia, it's not that uncommon. But I have only heard of one other person who was born a boy and became a girl because the doctor felt like they just couldn't actually make her a convincing other gender. And so I haven't heard from them, but I think they were doing fairly well when I talked to them before. So I don't think it's as rare as people talk about it. I think people really don't talk about it. So I think getting in contact, even with transgendered there are other syndromes and other things that have some of the same features. So I think getting a support network and knowing what to do, what to talk about, things like that would be really crucial as your child grows and develops, because you need to know what to say and how to be helpful and not in any way be judgmental or do something that could be very negative. So, I don't know what that is, but I definitely think there are some organizations that have that information.
Elizabeth, I want to thank you very much on behalf of the more than 100 people that participated in tonight's presentation. To those of you that have asked to be able to consult with her individually, she has graciously agreed to have her email shared, and we'll be glad to take your questions. I will send that in a separate email. I would encourage you, please, to fill out the survey that comes post-webinar so that she can receive your feedback on what you thought about tonight, and we can help improve and build on our webinar series. So I thank everyone who participated, and I most especially thank Ms. Ruth for her dedication to our families and for her time in presenting tonight. Thank you.
Thank you so much for having me.
Good night.
Good night. Bye-bye.